Hello, I'm Dr. Ken Landau. Thanks for joining us. This is Well Now Doctor. We're going to be discussing Gastro-Esophageal reflux disease. Very important condition, at least as far as symptoms are concerned. Lots of people suffering the condition, maybe not daily, but certainly weekly. And we know that Gastro-Esophageal reflux disease came from seeming obscurity to a major medical condition. We have to discuss what causes the condition, what do we know about the condition, what are the symptoms. Is it simply heartburn, or is there something more to it than that? Can you get rid of gastroesophageal reflux disease by simply watching your diet, maybe not eating too much, maybe avoiding chocolate or coffee or caffeine? Maybe all you have to do is sleep on an extra pillow or two so your head is elevated a little bit? Well, what about associated conditions? Now we talk about gastroesophageal reflux disease might not be just associated with heartburn or maybe some reflux of solid material, we call it regurgitation, but maybe it's associated with sore throat, pharyngitis, laryngitis, maybe it's associated with recurrent ear infections, maybe it's associated, according to some people, with asthma. What do we know about those conditions, those associations? Are they real? Are they statistical? Or what are they? And then, of course, there's the issue of how do we make the diagnosis? What are the potential complications of gastroesophageal reflux disease? If you have acid sitting in your esophagus, supposedly that's the disorder, well, is that a problem? What causes it? What's the basic underlying mechanism associated with gastroesophageal reflux disease? And then, of course, once we make the diagnosis, what are its complications? Complications of untreated disorder. And then how do we treat it? Is treatment best avoidance of foods? Is the treatment best taking some kind of medicine? Maybe you go to the drugstore and get a Tums or a Rolate or some other kind of antacid. How do they work? Where do they fit in? And then, of course, we have more modern medicines. We have what are known as the histamine receptor antagonists. Those are drugs that prevent the production of acid by the stomach. Are they adequate? They're very commonly used. Well, how do we compare them to, say, the more modern medicines, the stronger medicines, the medicines that are so frequently advertised on the television, medicines like Prilosec and medicines like Nexium? Are they better than the medicines you get without prescription? How do they fit in all together? And where does surgery fit into the whole story? We know that surgical treatment has been talked about an awful lot, getting a lot of press. If you have the surgery, does that free you up from taking the medications? Does it cure the condition? Does it placate the condition? What's the role? And then, of course, we have to decide if you get rid of the condition, do you get rid of all of the potential complications? And what are those complications? But first, you have to realize that 40, 50 years ago, the condition of gastroesophageal reflux disease was really considered insignificant. It was an obscure condition. Nobody paid much attention to it. All of the attention from upper gastrointestinal symptoms was associated with peptic ulcer disease, gastric ulcer, duodenal ulcer. But we sort of have conquered them. You don't hear much talk about them anymore. And instead, this once obscure condition, gastroesophageal reflux disease, has come to the fore. And lots, tens of millions of people suffering from the condition. Well, its modern history doesn't go back all that far. It only goes back to about 1935 at the Mount Sinai Hospital in New York City when Dr. Asher Winkelstein first described it. Well, from its humble roots, we know that it really is an important condition. It causes people to take time off from work because they think they're very sick. They think they have upper intestinal problems. It causes reduced function at work, reduced function and quality of life. It causes major problems, especially when it's associated with nocturnal reflux. It's one of the most common reasons for gastrointestinal consultation. See the doctor not only because you have the heartburn, but now, even more importantly, it's the heartburn that's resistant to acid suppression. Now, you have to realize that in the eyes of many doctors, and certainly the overwhelming majority of the general public, gastroesophageal reflux disease is a disease that's associated with too much acid production. You have too much acid, and the acid doesn't stay in the stomach, it gets back into the esophagus. And we know that in some degree, that's probably true, that you do have acid that's in the wrong place and it causes some kind of symptoms, but it's important to realize that gastroesophageal reflux disease is not a disorder of excessive acid production. The acid production in people with GERD is exactly the same as it is in otherwise normal people, no different than a healthy population. And as a matter of fact, we know that most people, if not all people, have reflux of stomach material into the esophagus, but the overwhelming majority of those people have absolutely no symptoms. They don't know when it occurs, doesn't cause any problem, and is just a part of normal physiology, just as blinking is. We all blink. That's not a disorder. Well, what we have to realize is that some people have pathologic reflux. They have reflux that causes symptoms. So now we have to have an arbitrary cutoff between normal reflux and abnormal reflux. And we don't really know what that cutoff is because, as we're going to discuss, making matters more confusing, not all people who have disease related to the reflux know that they have the reflux. So it's quite possible that you can develop an ulcer inside your esophagus because of reflux and have absolutely no symptoms, and even worse, you can have complications from that acid being in the esophagus or something being in the esophagus, causing problems, causing erosions, causing ulcers, and then it could go on and cause strictures or maybe be associated with some of the other complications, and you don't even know that you had the disorder to begin with. So what do we know about this condition? Well, one of the first things you have to realize is that it's becoming more common, and one of the associations, and we believe that it's a real association, is that where there's more gastroesophageal reflux, there's more obesity. And we know that there seems to be a major association between people being too fat, and especially too fat around the belly, not necessarily too fat around the hips, but too fat around the belly seems to be associated with an increased incidence of gastroesophageal reflux disease. So what do we know about the origins? Well, originally, once upon a time, this was peptic esophagitis, or it was thought to be a hiatal hernia. Hiatal hernia was where the stomach moved up through a hole in the diaphragm where the esophagus goes down, and now this part of the stomach, either permanently or most likely temporarily, was up in the chest rather than in the belly. So that was our original concept of the disorder. Changed quite consistently, changed quite dramatically since then. Now we think that, well, it's probably a motility disorder. And it's a motility disorder where we have some abnormality of the contractions of the esophagus, and now we know that at the bottom of the esophagus, where the esophagus goes into the stomach, we have a sphincter, we have, in effect, a valve. And that valve normally is shut, but sometimes it's open. And this lower esophageal sphincter is very important in the whole concept. Then we thought, well, it's got to do not just with the motility disorder, but it has something to do with acid, and the acid peptic disorder. Now we think it's probably related to all of those conditions. And how did we get our different ideas about the condition? Well, it had to do with the different kind of tests that we had. So when we only had the barium swallow, when you swallow some barium and they take some x-rays, that's when we got the idea about the hiatal hernia, about part of the stomach moving up into the chest. But in 1971, it was thought, well, geez, everybody has some degree of hiatal hernia. All you have to do is press on the stomach hard enough And we get some of this displacement. So it was thought that it had to have something more to it than that. Then we learned about the esophageal sphincter, the lower esophageal sphincter, with some manometry, with the ability to go and measure some pressures, and then we could look down, and when we looked down, we could see that, aha, a lot of people had some esophagitis, a lot of people had inflammation of the lower part of the esophagus, and that was the condition. Then we started doing some pH monitoring, and when we did the pH monitoring, we found that that was very interesting because not all people had significant amount of acid. Maybe it was just a little bit of acid. Maybe it wasn't even acid. Maybe it was alkaline material that was causing the problem. And you can't tell the difference. Then we had the proton pump inhibitors, the medicines like Prilosec. They came on the market in the late 1980s, and it was thought, well, what we ought to do is we ought to define gastroesophageal reflux disease simply by giving people that medicine, and if the symptoms went away, then they probably were suffering from gastroesophageal reflux disease. But that's not a very good idea. It's obviously wrong because there's a lot more to the condition than simply the production of acid or acid being in the esophagus. Now it gets even more difficult because when we look down the esophagus and we find those people who have symptoms, and we look at the esophagus, we find that the esophagus oftentimes looks perfectly normal. We don't see any erosions. We don't see any inflammation. And as a matter of fact, the overwhelming majority of people who are suffering from gastroesophageal reflux disease are suffering from a condition that we call non-erosive reflux disease. So these people with non-erosive reflux disease have nothing wrong as far as we can test, but they do have symptoms. And the symptoms appear to be related to some of the reflux material going from the stomach into the esophagus, but it doesn't cause any obvious clinical abnormality other than symptoms. And then we have a variety of treatments for those symptoms, and they work to a fair degree, but not nearly as well as most people believe, and certainly not nearly as well as the television ads would suggest. So then we started treating with the antacids, and then we had the histamine blockers, and then we had the proton pump inhibitors. And remember, it was related, it was thought that all you had to do was treat people with these kind of medicines, and we treat them indefinitely, and they wouldn't have any kind of problem because we could get rid of the acid. But that's not true. And not only isn't it true, there's a complication somehow related known as Barrett's esophagus, where instead of having the normal kind of cells that line the esophagus, in the esophagus now we have cells that normally line the intestinal tract. These are called columnar cells. Well, now we know that we have a major problem with refractory disease. People who have gastroesophageal reflux disease, people who have heartburn, who are taking the medicine oftentimes appropriately, but seemingly not getting any better. And now we have a list of other conditions, other syndromes that are associated somehow with gastroesophageal reflux disease. These are the conditions that I mentioned: the pharyngitis, laryngitis, middle ear infections, asthma, sometimes recurrent pneumonia. And we have to figure out where they fit into the whole story. So once upon a time, it was a simple disease. All we had to do was look and find a hiatal hernia. That was supposedly it, an abnormality of your lower esophageal sphincter, and that was it. Now we have a condition that seems to be more associated with the whole story of gastroesophageal reflux disorder, and it has to do with the transient relaxations, the temporary relaxations, when they're not supposed to occur, of that lower esophageal sphincter. And now on top of everything else, we have the weakly acidic or maybe even the non-acidic reflux. Well, if we look at damage to the esophagus that we can measure, it only occurs in somewhere less than about a third of the people who have gastroesophageal reflux disorder. People can develop complications if they have some of the erosions or some of the inflammation, and the complications may be important. We can develop some bleeding and some scarring. We can develop narrowing of the esophagus, and that can lead to disorders of eating. We can't get the food all the way into the stomach, so it sort of clogs at the bottom of the esophagus. We can develop strictures, and supposedly we can develop cancer of the esophagus. Well, how common is the disorder? It's extraordinarily common. We know that somewhere between maybe 25% and 35% of the people are going to have symptoms at least sometime during their life, and more than 60 million people here in the United States have symptoms at least monthly, with probably somewhere around 15 million people, 15 million people, suffering from symptoms on a daily basis. So if we look at symptoms at least monthly, maybe as many as 1 in 5 people here in the United States. If we look at symptoms daily, maybe as many as 1 in 15 people in the United States. And you contrast that with Asia, people relatively thinner over there compared to the United States, and we find the incidence, the prevalence of gastroesophageal reflux disease is maybe only 5%, 1 in 20. Well, clinically troublesome, about 6%, 1 in 16 people. And then we find that it's not just the heartburn, but it's actually regurgitation of food. That can occur in somewhere maybe as many as 1 in 16 people. Now, is it more common in Caucasians or in African Americans? Well, here in the United States, the symptoms, just the symptoms of gastroesophageal reflux disease, seem to be probably pretty common between the different races and ethnic groups, actually. On the other hand, the complications seem to be more common in Caucasians. So if you're white, you have a much greater chance of suffering from erosive esophagitis, erosions or ulcers on the inside of your esophagus, or this complication that we call Barrett's esophagus that might lead somehow to cancer, or cancer. Cancer occurs probably somewhere around 500% greater in whites than in blacks. So the question is, how do we define the condition? Well, that's tough. And as a matter of fact, up until relatively recently, we didn't even make an attempt other than clinically to define it. But then a group of experts got together in Montreal in 2006 and came up with a consensus diagnosis. Now, you have to realize that the diagnosis is a lot more difficult than getting a group of doctors in a room and trying to come up with some sort of statement that defines a condition. So the way they defined it is they said it's a condition that develops when the reflux of the stomach contents causes some sort of troublesome symptoms, maybe even causes a cough. But the question is, what is a troublesome symptom? And according to them, it was a symptom that would interfere with the quality of life or cause symptoms. Well, right away we say, well, what about the non-erosive reflux esophagitis? That wasn't even really considered because that wasn't something that would cause a demonstrable problem. That's including a condition known as functional heartburn. People just seem to have heartburn and they don't even have the reflux. So what can we say about this condition? That a lot of disorders don't fit their particular definition. We still don't have a gold standard for the definition. So where does non-erosive reflux disorder fit? What about gastroesophageal reflux disease? Well, you can have it either with erosions or without erosions. And do we classify the condition on the basis of symptoms? Well, we already said you don't have to have any symptoms and you can have major tissue pathology. So do we instead classify it on the basis of tissue pathology? Well, if we classify it on tissue pathology, tissue abnormality, tissue injury, microscopic abnormality, well, there are a lot of people who fit into the condition. They have the symptoms, but they don't have those abnormalities. And as a matter of fact, as we said, that most people who have the symptom of heartburn do not suffer from erosive esophagitis. Some people have hypersensitivity syndrome. They get a little acid, but not enough to be considered abnormal. And they have symptoms because of that. Or other people have heartburn or a functional syndrome and have nothing that we can demonstrate is an abnormality. And as a matter of fact, we even have the condition in children. It's not uncommon in children. As a matter of fact, it seems that if we look at any age group, it's increasing in incidence in the pediatric group more commonly than any other group. So if we look at infants, we find that the disorder has increased from about 3.5% to about 12% over a period of the past several decades. And if we look at children and adolescents, we find that the incidence has increased somewhere between maybe 30 and 50%. In childhood, we know that it's a frequent condition. It frequently leads to chronic gastroesophageal reflux disorder, a disorder that lasts for years or even several decades. We know that it has an increased likelihood of being severe, and later on in life, when a person gets to be 30 or 40 or 50, those young people with relatively severe gastroesophageal reflux disorder may go on, and those are the people who develop the erosions and they develop the Barrett's esophagus, and they have an increased incidence of suffering from the malignancy. So what do we know? It's long-lasting in children. About 50% of the children who don't have any other kind of abnormality, who have gastroesophageal reflux disease, still going to be symptomatic and significantly symptomatic by about 10 years. What do we know about risk factors for gastroesophageal reflux, or GERD? Well, it seems that anything that contributes to some sort of an impairment of the junction of the esophagus and the stomach may increase the condition, but we also know that you can have a stomach disorder, you could have an esophageal disorder, and several other disorders that may lead to the condition. So we know that there's certain genetic proclivity, tends to run in families. The older you get, the more likely you are to have some sort of symptom. We know that it's associated with obesity, as I mentioned before, and pregnancy. Pregnancy puts a big mass in the abdominal cavity, the pelvic cavity, and when it does, it pushes the stomach and its contents somewhat backward. Certain kind of trauma to the belly can lead to this condition. We know that anything that increases the pressure inside the abdomen can lead to an increase in gastroesophageal reflux. So what do we know? Well, obesity, that stands to reason. Heavy lifting, when we just increase the pressure on the muscles in the abdomen, those muscles press on the stomach, and especially if we've eaten recently, that can push some of the material upwards. But we know that it's associated with more than straining and lifting, because we know the symptoms are very common at night. We know that bending over can cause the problem. Coughing can cause the problem. Pregnancy seems to lead to a marked increase in gastroesophageal reflux, and so does being either obese or overweight. Now, if we're talking about obesity, you have to realize that it's abdominal obesity. So if we divide men and women, we say that women tend to develop more fat around the hips, unassociated with gastroesophageal reflux disease. On the other hand, men tend to develop more fat around the midsection, the belly, that is associated with gastroesophageal reflux. So we know that your waist circumference, rather than your total body weight or your body mass index, seems to be the most important. And it seems that the more abdominal obesity you have, the more fat you have around your midsection, the greater the rate of the complications, the erosions and the Barrett's esophagus and the adenocarcinoma. Now, the complications of the fat, the complications of being fat, of having the fat around your abdomen, it seems that the fat cells around your abdomen are different than the fat cells around your hip. They do different things, they metabolize differently, they produce different chemicals, and they lead to different problems. And one of the problems is that the fat cells accumulating around the abdomen tend to increase the amount of inflammation, and when they increase the amount of inflammatory chemicals, that's associated with some of the change in the esophagus that leads to either the erosions or the what we call metaplasia, the wrong kind of cells. Remember, the intestinal cells being there instead of the esophagus cells, and then that can lead to neoplasia. Now, we know that there are two different routes that the fat takes to lead to gastroesophageal reflux disease. So we know one of them is dependent on just the fat being there, taking up a lot of space, increasing the abdominal pressure, and that leads to more gastroesophageal reflux. We understand that. That seems to make sense, but you have to realize that those fat cells, as I mentioned a moment ago, are producing the adipokines and the cytokines and the chemokines, and they're producing insulin-like growth factor and insulin and a whole bunch of other kind of substances, and as a result, those abnormalities, independent of just the fat taking up space, can lead to symptoms. Now, we know that obesity seems to be associated with this whole condition. And the mechanisms are in part known, and we think there's a major association, and we certainly know that there's more GERD in areas of the world where there's more obesity. We know that obesity is increased more in men than in women, symptoms more in men than in women. We know that abdominal obesity has occurred more in men than in women, and we know that it occurs more in Caucasians than in African Americans. So there's good association. We also know that pregnancy is associated with gastroesophageal reflux disorder. We know the symptoms occur in the first trimester. Well, baby isn't that big, or the fetus isn't that big. So maybe about a quarter of the women are going to develop first onset, new onset gastroesophageal reflux disease in the first trimester, but that increases to about 40% in the second trimester and probably somewhere around 70% in the third trimester. Does not seem to be associated with either race or the pre-pregnancy body mass index, or even the weight gain during pregnancy has to do with chemical changes that occur in the body, and that's in association with the mass. Now, it's interesting that we know that the weight gain during pregnancy is unassociated with the symptoms that develop during the pregnancy, but if we look at women a year later, it seems that the amount of weight that they gain during the pregnancy is associated with the delayed onset of the gastroesophageal reflux disease. Now, we have another condition. We have that bacteria that's been associated with the ulcers. We call it the Helicobacter pylori. And some people say that we should screen for that, and if we find it, we should treat that, and we should treat it with some antibiotics. And there's a controversy regarding whether there's any association between Helicobacter pylori, the bacteria, and the symptoms of gastroesophageal reflux. We know unquestionably it's associated with the peptic ulcer disease. Well, as a matter of fact, having that bacteria in your stomach might actually help prevent some of the complications of gastroesophageal reflux disease, might help prevent some of the erosions, might help prevent the Barrett's esophagus, might help prevent some of the cancer. And as a matter of fact, there are some people who, when their Helicobacter pylori is eradicated with antibiotics, some of those people develop the GERD for the first time. Well, what do we know about this whole subject with Helicobacter pylori? We know that it seems that it's unassociated for the overwhelming majority of people, but might have some protective effect in other people. And we know that the presence of the bacteria does not necessarily mean that you're going to have some sort of stomach symptom. So just because the bacteria is there does not mean that you'll develop peptic ulcer. So if the bacteria is sitting there harmlessly, question is, why treat it? And then the other thing is that we know that there's a lower incidence of the complications of GERD in people who seem to have a greater incidence of the Helicobacter pylori. So complicated story, but basically a story that we should overlook, at least at the present time. So now the question is, what kind of symptoms does a person have who suffers from gastroesophageal reflux disorder? And as a matter of fact, if you have GERD, you don't have to have any symptoms. And in spite of the fact you don't have any symptoms, you may well have some of the complications of the disorder. And remember, we're talking about a condition where even though the general public identifies gastric acid as a major component, we don't know what the story is, but it certainly seems that the people are not producing excessive acid. And it seems like even when we stop the production of acid, pretty much effectively with those proton pump inhibitors, the Prilosec and drugs like that, well, we can still have the symptoms. So there's something more to the story than that. So the symptoms, you can have no symptoms, or the most common symptom is simply heartburn. We call that pyrosis, where you can have some burning, and you can get the burning in your central chest, or maybe it's going to be in your throat. Maybe you have a sour or bitter taste in your mouth, or it's in your throat. Tends to start somewhere under the breastbone and migrates. Maybe it doesn't even migrate. Maybe it can just stay in the center part of your chest. How long does it last? Well, it doesn't last too long. Usually it lasts only a few minutes. Symptoms thought to be due to the presence of acid or some sort of abnormal chemical being in your distal esophagus, the esophagus just above the stomach junction. When you have the reflux, from the time the reflux occurs until the time the symptoms develop tends to be less than a minute or so. We know sometimes people have symptoms that can be atypical, and they can actually mimic coronary artery disease. You might think you're having angina. You can have, as a reaction to that acid being in your stomach or something being in your esophagus, you can have some esophageal spasm. And that spasm can feel just like a coronary artery disease. And as a matter of fact, you can have nocturnal symptoms. So it doesn't mean that you just had to eat. You can go to bed, and in the middle of the night, you may well get up because you have problems. You have these kind of symptoms. You have the pressure in your chest. You have the terrible feeling in your mouth. And that can be a symptom. And as a matter of fact, people who have the nocturnal symptoms seem to have a higher incidence of having some of the complications, those esophageal erosions and the Barrett's esophagus, and maybe even the tumors. And it seems certainly that if you have the nocturnal symptoms, it can be associated with a disorder of your sleep. So we also know that you can have regurgitation of solid material. And the material can get into your mouth, not associated with retching. That can be part of the heartburn symptom. And people who have heartburn, we find that those individuals can have some dental erosions, enamel erosions. Why? Because theoretically the acid getting into your mouth, and people who have the condition can suffer an increased incidence of hoarseness and the feeling like you have a lump in your throat or something is caught in your throat, or pharyngitis or sinusitis or cough or asthma or pulmonary fibrosis, getting to be a common condition nowadays. Recurrent otitis media, even sleep apnea have been associated with gastroesophageal reflux disorder. And we have to say, are these extraesophageal conditions, are they really associated? We know that there is an association, a statistical association, somewhere between an increase in 20% to twice as frequent with some of these conditions in people with GERD. But whether it's a cause and effect or just a statistical association seems to be questionable, especially because when we treat with those acid-reducing medicines, those extraesophageal symptoms, the pharyngitis, the sore throat, the globus, the asthma, well, it doesn't seem to go away. Now, what are the disorders that can be mistaken for this condition? Well, we have a lot of disorders that can be mistaken for gastroesophageal reflux disease. We already said that it can mimic coronary artery disease, so we have to sort that out. That's obviously very important. Gallbladder disease can cause the same kind of symptoms, and so too can cancer, especially in an older population, especially cancer of the esophagus, which is associated with this disorder, or cancer of the stomach. We know peptic ulcer disease frequently can cause the same kind of symptoms. Certain kind of infections can lead to it. If you take a medication or if you swallow something in a suicide attempt that's caustic, that can burn the esophagus, burn the lining of the esophagus, cause the same kind of problems. We have functional disorders. We have certain kind of psychiatric or emotional or psychological disorders. We have a condition known as achalasia, where there's a narrowing of the junction between the stomach and the esophagus, and we can have a spasm. All of those can be associated. Now, the question is, when we look at gastroesophageal reflux disease, and we look at some of the common problems, we say, what are they? Well, one of the problems right now we have is with erosive esophagitis. We have erosions in the esophagus, and that causes a lot of people to go to the doctor, but so too do symptoms that persist after the disorder is appropriately treated. So we appropriately treat the gastroesophageal reflux disease with our medication, but the people still have symptoms. Well, why do people have symptoms? We always think that the symptoms are a result of acid where it shouldn't be. Acid from the stomach gaining access to the esophagus. But we've already said that that probably is not a major issue. Well, now we think that the disorder is a motility disorder and maybe a mucosal disorder. Maybe it's the mucus lining, the mucous membrane that lines the esophagus. Maybe that's where the problem is. We know that you can get symptoms when the pH of the reflux material is less than 4, no argument about that. But now we know that if the pH is between 5 and 6, you can still have the symptoms, and even when the bile all the way from the duodenum, that's the esophagus, goes to the stomach goes to the small intestine. Well, even material from the first part of the small intestine can gain access back through the stomach into the esophagus, and that can cause what we know as a bile acid reflux. And when you develop that, that's typically alkaline. Well, we know that the bile acids, especially in the presence of stomach acid, can have a noxious effect on the acid and the pepsin that can get back into the esophagus. And we know that if a person's had an operation on the stomach, maybe for peptic ulcer disease or maybe some kind of malignancy, or maybe even some other kind of surgery due to treatment of weight loss, well, all of those can be associated with an increased likelihood of this particular problem. And as a matter of fact, when we look at people who are still symptomatic after normal medications for gastroesophageal reflux disease, after we do everything right, we know that a significant number of people are going to have symptoms still, and those people might be having the bile acid reflux. Well, that's obviously a major problem, a problem that can be treated sometime with specialized kind of medicines, maybe some aluminum hydroxide and sulforaphate. Maybe that's going to be able to bind some of the bile acids, or maybe we use mursodeoxycholic acid that we use typically for gallstones, but that might also help. So now we have a condition where we have the gastroesophageal reflux disease, and we have to divide it into one of two groups. And it's very important to make this distinction. And the distinction is that, number one, it's a progressive disease, that we progress from the non-erosive disease to the erosive disease, erosive esophagitis, and then we progress from there to the Barrett's esophagus and cancer. So if you develop the condition, we have to stop its progression. That's very important according to this particular concept. But another concept that's probably correct is that each of these abnormalities is physiologically distinct and non-progressive. So if you develop the symptoms of erosive esophagitis, they're probably not going to progress to Barrett's esophagus and not going to progress to the adenocarcinoma, even if we follow people over decades. And as a matter of fact, people have been followed once they're cured or once they're appropriately treated, and it seems that there is not a progression. So the strictures, the narrowing of the junction doesn't seem to occur in a significant percentage of people who have been treated. It seems that the Barrett's esophagus doesn't seem to occur unless you happen to have very bad erosive esophagitis, and it seems like the incidence of cancer is extraordinarily low. Now, hiatal hernia was once upon a time, as we mentioned, thought to be a central player in this whole disorder, and then we decided, well, it probably wasn't because everyone had it. Now we think that when a portion of the stomach goes through the opening of the diaphragm and gets back into the chest cavity, that it's easier for the acid or for stomach contents to irritate the esophagus. And that's thought to be the case at the present time. But it's also thought that there's a reduced clearance of the acid or the material from the esophagus. And that's where the whole concept that GERD is really a condition, a motility abnormality, where that comes from. So it's not the number of the reflux events. It seems that maybe the dominant mechanism is how much material gets into the esophagus and how long it stays there. Well, we have three components that are extraordinarily important to this whole discussion. And the three junctions, the three separate compartments that separate the esophagus from the stomach, separate basically the chest from the abdomen, are number one, the lower esophageal sphincter. Number two is the diaphragm. The diaphragm we all think of as the baffle that pushes the lungs up and down. Well, it also is very important in gastroesophageal reflux disorder. And then we have what's known as an anatomic flap valve, flap, F-L-A-P valve. Well, lower esophageal sphincter. We know that it's a little more than an inch and a half long. Typically, it's constricted. So on a normal basis, it's constricted. And if we measure our blood pressure, we know it's 120/80. That's normal. Well, if we measure the pressure of the lower esophageal sphincter, it's closed at a pressure of somewhere between about 10 and maybe about 35 millimeters of mercury pressure. That's important because it's relatively low, and it varies considerably. The pressure varies considerably with activity or with sleep or with meals. We also know there's a longitudinal layer of muscles in the esophagus that plays a very important role in all of this. We know that the diaphragm is very important because, after all, the diaphragm separates the chest from the abdomen. So the esophagus has to go through the diaphragm. And as a matter of fact, the crural diaphragm acts to help keep the stomach in the abdomen. And as a matter of fact, the diaphragm goes up and around and forms a teardrop-shaped external sphincter. So we have the internal sphincter within the esophagus itself, and then we have an external sphincter, and the external sphincter is the diaphragm wrapping around the esophagus, but sometimes it develops a little opening, and then sometime the stomach or portion of the stomach can get into the chest, and then we've in effect ruined some of the ability to keep the acid out of the esophagus. And then in addition to all of that, we have what's known as an anatomic flap valve, and that keeps the lower esophageal sphincter inside the gut, inside the abdomen. It maintains the sharp angle, the acute angle between the esophagus and the stomach. But unfortunately, if it's disrupted, it allows the hiatal hernia to form and allows the stomach to get up into the chest cavity. And when it does that, then we get some more symptoms. So we have people who have degradation of the area of the valve, of the mechanism of the separation, and it can be a subtle change or it can go on to be a major change like a hiatal hernia. And as a matter of fact, the hiatal hernia may be present either for a little bit of time or for a lot of time. It can be present intermittently. It can seem to come and it can go. Now, as if this weren't complicated enough, we have to talk about some of the acid, where the acid is and what the acid does, and is the acid really important or not? And we'll do that next week when we come back.